All right. Now it's officially 9 o'clock and we're officially recording. So welcome back for week 2. So we finished doing anatomical directions on Friday. We're going to apply some of that stuff today, like we'll talk about osteokinematics. But we're going to talk about the bones of the shoulder girdle today and the bony landmarks. I sent out an email probably like 8 o'clock last night saying, hey, if you could, bring your Lab 1 sheet to class tomorrow. If you don't have it, don't panic, but it's ideal if you do. And if you have it up, if you have your laptop with you, you can just pull it up. It's in Canvas as a Word document if you want to type into that as well. So we're going to basically run through that Lab 1 sheet and then see what we can get to as far as joints and all of that stuff. So I'm going to try to use the anatomy app for most of this discussion. But that said, if you look at the PowerPoint that's up, it'll let me advance. Maybe, there we go. So if you look at the PowerPoint that's up, you'll see labeled diagrams like this. It's from a book, I think it's called The Atlas of Human Anatomy or something to that effect. It's by a physician named Frank Netter. And so those illustrations are how I learned this stuff more than 20 years ago, so I think those will be helpful for you. And so they're embedded in the slideshow, but they're also a separate PDF in Canvas under the shoulder module if you want to use that. So those are on there. And like I said, there's different views. If you keep clicking on the slideshow, there's different views of the clavicle with all the stuff I'm going to talk about labeled. But rather than just use this that's in the slideshow, because it'll look like I'm reading the slideshow to you and I don't know what I'm talking about, I'm going to try to use the anatomy app. So I'm going to back the slideshow up a little bit. We'll escape out and we'll go into the anatomy app. The unfortunate side effect of using the anatomy app is then I have to be over here in front of the computer. That's okay. All right. So the shoulder girdle. So there's 3 bones that make up the shoulder girdle. Those are the clavicle. So the clavicle is, the more colloquial name for your clavicle is your collarbone. So the clavicle is this guy right here. So your collarbone. Then the second bone is the scapula. So the clavicle. The scapula, the more colloquial name for the scapula is your shoulder blade. So now we don't have to say that anymore. Now we're saying scapula. And then the last bone of the shoulder girdle is the humerus. So the humerus is your upper arm bone. So clavicle, scapula, and humerus. All right. So the first thing that we're going to do then is to talk about the landmarks on the clavicle. So what I'm going to do on the slideshow or on the anatomy app is to just isolate his clavicle. So again, your clavicle is your collarbone. Click on that. And then we'll isolate it. All right, so you're looking at the right clavicle. So there's 3 landmarks on the clavicle that I want you to know. So there is the sternal end. So the sternal end, and I should probably go in order. Oh, good, hang on. All right, so the sternal end of the clavicle is the medial of the 2 ends. So remember, you're looking at his right side. Okay, so it'd be like if I'm facing you, you're looking at this clavicle on that skeleton. So this aspect, if you're looking at the screen on your right side, that's the medial aspect. That's closer to his midline. Over on the left side of the screen, that's the lateral aspect. That's farther from the midline. So the sternal end is the more medial of the 2 ends. When we get to lab tomorrow, we'll actually have clavicles on the table that you can play with, and scapulas and humeruses. And so the way to differentiate between the 2 ends, if you look at the sternal end, I'm going to spin the bone around a little bit. So now you're looking medial to lateral. You'll see that the sternal end is really big and round and fairly knobby, right? So that's an easy way to distinguish it. So the sternal end, between the 2, between the acromial end and the sternal end is the much rounder of the 2. The significance of the sternal end is that it's going to interact with the sternum. So if I go back and bring the full skeleton back, and if we'll zoom in a little bit, okay. So we can see, what you can see here is that the sternal end of the clavicle, the rounder end of the 2, interacts with the sternum. So the sternum is the bone in the middle of your chest, and there's 3 parts to the sternum. So it's going to interact with the manubrium of the sternum. Don't worry about that stone for now. Just know that it interacts with the sternum. And so that's going to form the sternoclavicular joint. So the sternoclavicular joint is on the back side of your page if you want the spelling for that. I'll refer to it as the SC joint a lot, and we'll also talk about it here on the slideshow in a minute. But the sternal end of the clavicle interacts with the sternum to form the sternoclavicular joint. And so that is, again, this little joint right here. All right, so other things. Now we're going to go over here to the lateral or the distal end of the clavicle. So that, go back to isolating it. So that is the acromial end of the clavicle. So that's your second landmark. So the acromial end, and again, what you'll notice, so whereas the sternal end is big and round and knobby, the acromial end is fairly flat, kind of rectangular. And so if I spin it around and look at it lateral to medial, again, fairly flat, kind of rectangular. So that's the acromial end of the clavicle. So it's the more lateral of the two, farther from the midline. The significance of the acromial end is that it is going to interact with the scapula. So the acromial end of the clavicle interacts with a part of the scapula called the acromion. The acromial end interacts with the acromion. And that forms your acromioclavicular joint. Again, the spelling is on the back. So I'll refer to that as the AC joint a lot of the time. So that's the significance there. Yep.
What is the number?
Good question. I meant to get to that, but good question. So when we get to lab tomorrow, up on the front table, I'll have key bones for you. And so the key bones actually have numbers on them, and then there's a key and answer key. So if you want to use, if that's a good way for you to learn them, then you can do that. At this point, it's kind of antiquated. I don't think anybody's really going to use that, but that's why the number column's there. Good question. All right. Anything else? Because at the moment, I'm throwing a bunch of terms at you that you don't really understand, but they'll make sense as we go along. All right, so there's those two. So that's the acromial. So then the other thing that I want you to know is the connoid tubercle. So if we go back, now you're just looking at that anterior, that front view of the right clavicle. The connoid tubercle is this little bump right here on the inferior aspect. Okay, so then if I spin it, now I'm looking at the underside, so I'm looking at the inferior aspect of the clavicle down here, and so this little bump that I'm mousing over, that is the connoid tubercle. The significance of the connoid tubercle is that is the point of insertion of the Coracoclavicular Ligament. And I'll spell that for you here, and then I'll spell it verbally in a second. All right, so let me pull the screen up. So, there we go. Up. See how well this blue marker works. So what inserts there? Oh, I got a green. So what inserts at that landmark is called the Coracoclavicular Ligament. So Coracoclavicular, C-R-O-A-C-L-A-V-I-C-U-L-A-R, Coracoclavicular. And so one of the things that you've probably already kind of put together is that when we're talking about things like ligaments, so ligaments connect bones to bones, and I'll tell you that repeatedly, but ligaments connect bones to bones. And so this is the coracoclavicular ligament. And so typically ligaments are named for the two bones that they connect. So in this case, the coracoclavicular ligament runs from the coracoid process, which is on the scapula, we'll talk about that guy in a second, to the clavicle. So those are the two things that it connects, so that's the name of the ligament. So the coracoclavicular ligament inserts there at the connoid tubercle, and again, that's the significance of that landmark. So those are the things that I want you to know on the clavicle. So like I said, when we get to, and these same questions will probably be on the test as well, but certainly when we get to the lab quiz in a few weeks over the shoulder, one of the ways the questions will look will be you'll just see a picture of a clavicle. It looks like this. And so it'll say, okay, this is the right clavicle, anterior view. You're looking at the right one from the front. Click on the acromial end. And so you'll just click somewhere down here near the acromial. And so like I said, I'll draw an invisible box that you won't be able to see, kind of in this area. So as long as you click inside that box that I drew, that'll be the correct answer. Or I'll say click on the sternal end, connoid tubercle, that kind of thing. And I'll also ask you about the significance. The significance of this landmark is it's the origin of biceps, or it's the insertion of coracoclavicular ligament, or whatever, those kinds of things. So that's how I'll ask you questions about those. All right, so any questions about the clavicle? Riveting stuff, I know. All right, so now we're done with that part, that first table on the lab sheet. So now we're going to talk about the scapula. So all the time I'm going to work on the right side, just because I think it's easier to be consistent. So I'm always going to work on the right side of the skeleton. So we're going to go from our clavicle here, down to our scapula, down to our shoulder blade. All right, so I'll click on that guy. Okay, I'll isolate it. I wish I knew how to make it not green when it's isolated, but wait. I'll slide it down so it's fully on the whiteboard. There we go. Is that good, or do you want is the screen better? Screen better? Okay, we'll do that. I'll just put it back up next time I need to write. Okay, so there is your scapula. So now you're looking at an anterior view. You're looking at the front side of the scapula. Okay, so the first landmark on there that I want you to know is called the Coracoid Process. So the Coracoid Process is this projection right here. So it kind of looks like a bird beak, but it's this anterior projection coming off the scapula. So the coracoid process, we just talked about one of the things that's significant about the coracoid process. It's the origin, the start of the coracoclavicular ligament. So that's an important thing to know about it. But the coracoid process is also an important site of muscle origin and insertion. So if a muscle originates somewhere, that's where it starts. And if a muscle inserts somewhere, that's where it stops. So you've got two muscles that originate at the coracoid process, one muscle that inserts there. So the two muscles that originate there, trying to decide if I can use the sideboard, we'll use the front board. So the two muscles that originate there, one of them is one that you're probably pretty familiar with, Biceps Brachii. So your big elbow flexor, Biceps Brachii, originates there. So I'm going to write origin here. All right, so Biceps Brachii originates there. Biceps Brachii actually has two heads. So biceps means two heads. And so it's only actually one of the two heads. It's the short head of biceps that originates there. Short head. And then, Cedric, can you see that? Okay. Maybe you might. Okay. And then the other one is Coracobrachialis. There. All right, so Coracobrachialis is the other muscle that originates there. So Biceps Brachii, the short head, and Coracobrachialis. And if you want the spelling for those are also on the Lab 2 sheet, and they're further down in the slideshow if you want those. Yep.
What's the first one?
Biceps Brachii. B-I-C-E-P-S space B-R-A-C-H-I-I. Constant spelling bee for me. All right, so those two originate there, and then it's the insertion of pectoralis minor. Which is not your big superficial chest muscle, it's actually the deep one, so one underneath that. Pectoralis minor inserts there. So for a little bird beak, it's actually a pretty important little structure. Coracobrachialis is something that you can palpate. It's pretty easy to find on most of us. If you kind of cup your hand around your opposite shoulder, about where your thumb is, there's a pretty obvious bony knob. If you start jabbing at it with your thumb, it's going to hurt. That's your coracoid process, right? So it's pretty obvious in most of us. And if you're really lean and or really skinny, sometimes it kind of pokes out. So anyway, that's it. All right, so that's the significance of that. The next thing that we're going to talk about is the glenoid cavity. So the glenoid cavity is on the most lateral aspect of the bone. So now you're looking at, oh, yep.
Oh, these things are almost going to be like in that really low.
On the quiz?
No, I mean like in that chapter.
Oh, I don't think the actual landmarks are, which is why I put that PDF up, because all this stuff is on that PDF. And most of them, if you look at it, because I think it's actually in our wife's textbook, they're all highlighted, the ones that you'll need to know. So, yeah, so they should be pretty easy to find on that. And same thing in the slideshow. I'm just doing it, like I said, so it doesn't look like I'm reading the slideshow to you, because that would be boring. More boring than this. Okay, so the glenoid cavity is this indentation on the most lateral aspect of the scapula. So the glenoid cavity, the significance of it is it's the socket for your shoulder, right? Because your primary shoulder joint is formed by the interaction of the scapula, specifically the glenoid cavity of the scapula, and then the humerus, which is your upper arm bone. So this is the socket that your humerus fits into. That's the glenoid cavity. It's a pretty small, fairly shallow indentation. So if I'm going to spin him back around this way, I'm going to bring the full skeleton back. There we go. So you can see there that it doesn't cover up much of the humeral head, as we'll talk about when we talk about the glenohumeral joint. It only covers up about a third of the humeral head at any one time, which is good, because that allows us to have lots of range of motion in our shoulder. We can go, really far into flexion, extension, abduction, etc. But it's bad in that the shoulder is fairly unstable. So because there's not a lot of bony overlap between the two, because that glenoid cavity is not very deep, the shoulder is an inherently unstable joint. So that's bad, but it is mobile, so that's good. So trade-offs there. So anyway, that's the glenoid cavity, and like I said, the view you were just looking at, all I did was kind of rotate him like this and pulled his arm off. All right, so we're going to go back to isolating the scapula. All right, so the next thing on there is the superior angle. Okay, so that's a throwback to Friday, kind of. What does superior mean? Anybody remember? Yeah, higher up, right? If something's superior, it's better. In an anatomical sense, it's higher up. So anything superior is higher up. All right, well, you can see if you look at I think it's more obvious from the posterior aspect. So now you're looking at the back, the posterior aspect of the right scapula. Pull it down a little bit. So the superior angle is this angle on top, because there's another angle we're going to talk about in a second, which is on the bottom. So the superior angle is the angle on top. It is this area right here. So the significance of the superior angle, it's fairly deep. It sits underneath your trapezius muscle, this muscle that's up here. It sits under that, so it is kind of palpable, but you really have to you have to palpate fairly deep to find it. So when I say something's palpable, I mean you can feel it, because there are some structures you can actually feel and find, and obviously there are a bunch of other structures that you can't. So this is one that you can find, but it is fairly deep. It's underneath your chest. But in terms of the significance, it is the insertion, so the stop of the insertion of a muscle called levator scapulae. So levator scapulae, oops, not that one, is LEVATOR, levator, like elevator, but without the initial E. So. Levator scapulae. So like scapula, but basically all we did was we moved the E from here to here. So you take the E off elevator, put it on the end of scapula. Makes it levator scapulae. So that muscle inserts there. And levator scapulae is an important scapular elevator. It brings your scapula up. So when you do things like shrug, you say I don't know, levator scapulae is involved in that. It's also a downward rotator of the scapula. So we'll talk about those two things here in a little bit. So that's the superior angle of the scapula. The next thing on there is the superior border. So the superior border, I'm going to leave the screen up for a second because I'll just need to pull it right back up. So the superior border of the scapula, so remember the superior angle is right here, this top part. The superior border is this, okay? So all of this line lateral to the superior angle is the superior border. It's not very exciting. There's no muscle insertion there or anything like that. So superior angle, superior border. All right. So then the next thing, so as far as significance, leave it blank. The next thing then is the medial border. So the medial border is all of this. Because remember, you're looking at a right scapula, so a right shoulder blade, from the back, so from a posterior view. So this would effectively be this guy facing away from you, so you're looking at a scapula like this. So remember that anything then medial is closer to the midline. So this border is closer to the midline. So this is the medial border. It's also referred to as the vertebral border. I will say medial, but you'll also see vertebral. So because your spine, the bones that make up your spine, those are called your vertebrae. So it's the vertebral border because it's closer to your vertebrae, closer to your spine. The vertebral border is going to, or sorry, medial border is going to be important because it is the insertion of a couple of muscles. So your rhomboid muscles, which are two that you might be familiar with. So we're going to go insertion. Rhomboid major. I won't write rhomboid twice. And then rhomboid minor. So rhomboid major and rhomboid minor both insert there along the medial or vertebral border. So in terms of quiz questions, one of the things I'll ask you, like I may highlight that landmark and say what muscle inserts here. And then you'll just have a list of muscles. You got to pick the correct one. So that's the way some of these other things will work into the quiz and into the test. So it's the insertion of rhomboid major and rhomboid minor, collectively known as the rhomboids. Both the rhomboids are scapular retractors. They bring your shoulder blades back. So that's what they do. They're important postural muscles. All right. So then we got the subscapular fossa. All right. We'll pull that down. So what we're going to do here is we're actually going to flip our view. I don't know why I turned that light on. We're going to flip our view, and we're going to flip back to the anterior view. So now you're looking at the front, the anterior aspect of the right scapula. Okay, so the next thing then, the subscapular fossa is essentially the entire anterior surface, all of this on the scapula. So it's basically, again, that entire anterior surface. So all of this is the subscapular fossa. So a fossa is some kind of an indentation. And as you'll see when we get to lab tomorrow, if you look at the scapula, the anterior aspect is kind of concave. It's curved in on itself. And so it's a fossa because, again, it's an indentation. So the subscapular fossa is most of that anterior portion of the scapula. Something else that's helpful with a couple of these fossas. So I mentioned the Netter illustrations. So this is from that diagram. So this is an anterior view of the right shoulder. And so you'll see some of the landmarks we just talked about. So we were talking about the subscapular fossa. So that is, I'm using the mouse for those watching the recording. So all of this is the subscapular fossa. Okay? So you'll notice that all of that area is red. So red means that there's a muscle that originates there. Anywhere where there's blue, that's where muscle inserts. And actually, when we go into lab tomorrow, you'll see that the skeletons on their right sides have reds and blues on them. Those are those things in 3 dimensions. So the reds are muscle origins, the blues are the insertions. So all of this area then is the subscapular fossa. Importance of it, or significance of it, is that's the origin of the subscapularis muscle. So right subscapular again, add an IS to the end. So subscapularis, that muscle originates there. That's one of your 4 rotator cuff muscles of the shoulder. So the rotator cuff muscles they rotate the shoulder, but they're actually really important for maintaining shoulder stability and maintaining shoulder health, if you will, keeping you from getting bursitis or fraying tendons or those kinds of things. So one of the 4 rotator cuff muscles, subscapularis, originates there. So that's the significance of the subscapular fossa. All right, back to the app. So I'm going to go back to a posterior view. And so we remember that the medial border, the one closer to the midline, is all of this, where our rhomboids insert. The lateral border is all of this then. So this kind of angled border here, that's your lateral border of the scapula. So the lateral border of the scapula, there's a couple muscles that originate out there. So the two muscles that originate out there are the teres muscles. So teres major and teres minor. So teres major and teres minor. T-E-R-E-S major, T-E-R-E-S minor. So teres minor is one of the rotator cuff muscles. So again, important for overall shoulder health, but also rotate your shoulder. So teres minor is one of the rotator cuff muscles. Teres major is one that's kind of just along your armpit. It's one that does the same thing as your lat. So when you do like pull downs or pull ups, those kinds of things, teres major is going to be involved in those motions. So both of those originate there on that lateral border. All right, the inferior angle. Let's see. All right. So the inferior angle is just that bottom angle. So down here. So the significance of the inferior angle, again, all of this. Because if anything's inferior, it's below, it's closer to the bottom, all of that. So the significance of the inferior angle is actually mostly clinical for us. In order to move your shoulder normally and without pain, you need to be able to rotate the scapula up. And so in order to evaluate their upward rotation of their scapula, what we do is actually watch and palpate, feel that inferior angle. So as they move their arms, if they abduct and they come out to the side, their scapula has to rotate up, and so we'll watch their inferior angle, make sure it's moving normal. So it's used clinically, but from an anatomical aspect, there's nothing really that originates or inserts there. Yep.
How would you see it move without moving correctly?
So what you would do is actually do both sides. So usually somebody's going to have like right side pain, but not left side pain. And so you can actually palpate their inferior angles. You say, okay, raise your left arm, raise your right arm. And so you can kind of tell. It depends on how much muscle mass they have as to how obvious it is. But you can kind of palpate with it and see if it moves as well on the injured side as it does on the uninjured side. Good question. Anything else? All right, good. So then the next thing is the supraspinous fossa. So supraspinous, supra sounds like superior, right? So supraspinous means above the spine. But in this case, we're not talking about your actual spinal or vertebral column. We're talking about another landmark on the scapula called the spine of the scapula. So this really obvious bony ridge right here is the spine of the scapula. And I'll mouse over it too for the video. So all of this is the spine of the scapula. Okay. So the supraspinous fossa, remember a fossa is an indentation. So the supraspinous fossa is an indentation above the spine of the scapula. And so what we're going to do then is I'm going to rotate this thing, and you're going to get a superior view of the scapula. So now you're looking down on the scapula from the top. So all of this is the supraspinous fossa. So when we get to lab tomorrow, the way that people often remember that is the supraspinous fossa kind of looks like a taco shell, like a hard shell taco. So it's a pretty obvious landmark. And so that sits then between that superior border and the spine of the scapula. Again, all that supraspinous fossa. So there's another of the rotator cuff muscles originates there, supraspinatus. So supraspinatus, S-U-P-R-A-S-P-I-N-A-T-U-S, supraspinatus. So supraspinatus is the most commonly injured of the rotator cuff muscles. So if you have a relative, usually it's guys over 50, happens in women too, more common in men, get a rotator cuff repair. Almost always the muscle they're getting fixed is their supraspinatus muscle. So that's the most commonly injured of the four. Yep, good question. Yep, so that is an origin. So that is the origin of supraspinatus. And then we talked about the spine, which again is this guy. All right, and so then the next one is the infraspinous fossa. So infra sounds like inferior. Inferior is below. So infraspinous fossa, we're looking for an indentation below the spine of the scapula. And so essentially, the infraspinous fossa is kind of all of this area underneath or below, not underneath, below the spine of the scapula. So all of this is the infraspinous fossa. And so to make that a little bit clearer, if we look at on the muscle origin insertions over here, you can see how big this red area is right here. That's all the infraspinous fossa. And so that is the origin of the infraspinatus muscle. So infraspinatus, I-N-F-R-A-S-P-I-N, infraspin, A-T-U-S. Infraspinatus. So infraspinatus is the last of our rotator cuff muscles, the only one we haven't talked about yet. It's an important external or lateral rotator. Second most commonly injured of the rotator cuff muscles. Oops, there we go. All right, so that's the infraspinatus fossa. And then the last landmark is the acromion. So the acromion is the tip of the shoulder. So this lateral aspect, and I'll look at it more of a lateral view, and then I'll rotate it down a little bit. So you kind of, there's superior angle or superior view. So all of this is your acromion. So again, your acromion is the tip of the shoulder, and all of us, pretty obvious. So your acromion is just that hard tip of your shoulder out there. That's your acromion. And then it runs in with, or it continues with the spine. So you can actually follow it once you find your acromion. You can actually follow the spine all the way back, depending on how much shoulder flexibility you have. I don't have much. So I can't go very far back, but it goes on, it is continuous with the spine. So that's the acromion. One of the things that throws people off, including myself the first time I had to learn this, it's easy to flip the coracoid and the acromion. I don't have a good way to tell you not to do that, but don't do that. So if anybody has a good mnemonic, I'm open to it. So if you come up with one over the next few days, that'd be helpful. But anyway, try not to mix up the acromion and the coracoid. All right, so, yep.
So the coracoid is just like the smaller part that juts out, and then the acromion is like the bigger one.
Yep, so this guy right here is the coracoid, and then this tip of the shoulder is the acromion. So yeah, your acromion's up here, and then my coracoid is up there. Yep, good question. Anything else? All right, so those are the landmarks on the scapula. Almost there. So now let's do the landmarks on the humerus. So we'll go back to our full skeleton. There he is. All right, so now let's talk about the humerus. So your humerus is your upper arm bone. And so you can see, again, it interacts with the scapula to form the primary joint of your shoulder. Okay, so center this guy a little bit. We'll isolate his humerus. So again, as always, looking at the right side, right humerus. So the first landmark on there is the head of the humerus. So the head of the humerus is pretty obvious, and it'll be super obvious on the plastic bones tomorrow. But if we rotate this, so now you're looking at a medial view, so you're looking at it from the midline. So all of this big dome is the head of the humerus. The head of the humerus, what part of the scapula does it interact with? You remember? Starts with a G. Glenoid, yeah. So the glenoid cavity or glenoid fossa. Good. So the head of the humerus, the significance of it is that it interacts with the glenoid cavity to make the primary joint of your shoulder, which is called the glenohumeral joint. Because joints or articulations are the interactions of two or more bones. Most of the time it's two bones, but sometimes it's more. So the primary joint of the shoulder, primary interaction of the shoulder, is between the glenoid cavity and the humeral head, so it's the glenohumeral joint. And you can abbreviate that GH, and you'll see that sometimes in my slideshow. GH is glenohumeral. So that's the primary joint of the shoulder. So that's the significance of the humeral head. One other thing I'd call your attention to on the humeral head is the fact that you can see it's nice and white, kind of a pearly color there. So the humeral head is lined with something called hyaline cartilage, or articular cartilage. So hyaline is spelled H-Y-A-L-I-N-E, hyaline. So that kind of cartilage in the joints is a really slick cartilage. So its job is twofold. It is basically to cushion impact between the two bones, but also to help the bones slide on each other. So if I bring back the full skeleton, there we go. So again, you'll see that the humeral head covered in hyaline cartilage, and there's a really obvious end to that cartilage. And then the same kind of thing here on the glenoid. So you can see that sort of pearly color there, not tan like the rest of the bone. So that's the articular or hyaline cartilage there, lining the glenoid. That's the articular or hyaline cartilage there, lining the humeral head. And so again, that's going to help those two surfaces slide nice and smoothly on each other. Because if they start touching, that's going to cause inflammation and pain and all of that. So we need them to slide nice and smoothly. And in fact, when you get, or if you get osteoarthritis, what happens is you've worn down that cartilage, and so the bones are kind of touching on each other some. And so then that's going to cause inflammation and pain. All right, so that's our humeral head. So that's its significance, interacts with the glenoid. And then the other things on there. So the anatomical neck. So I'm going to zoom in on the proximal aspect of the bone. So the anatomical neck is right here. So it is just lateral to the head of the humerus. It's where the bone narrows a little bit. So anatomical necks of bones, typically there's a narrowing, and sometimes they change direction. So in the case of the humerus, there's a little bit of a narrowing. So it's that really obvious ridge there where that hyaline cartilage ends. And so you get a little bit of a narrowing and then also a change of direction of the bone. So rather than being more of a medial lateral orientation, it's a superior inferior orientation, or proximal distal orientation. So that's the anatomical neck. Then the next thing is the greater tubercle. So again, at this point, you're looking at the right humerus from the front. So the humeral head is on the medial aspect, and so out here is our lateral aspect. So you'll notice, and you'll see the same thing tomorrow, that there are two knobs. So there's one knob right here, and then there's another knob, so there's a medial one, and then there's another pretty obvious bony knob right there. So right now we're talking about the more lateral of the two. That's the greater tubercle. And one of the things to know that'll be important when you see a real humerus is that, so all of this big area here is the greater tubercle. Because this actual projection is not very obvious, so you'll see this on the real bone tomorrow. The projection of the greater tubercle, not super obvious, but it includes all of this area. So that's the greater tubercle. The significance of the greater tubercle is that 3 of the 4 rotator cuff muscles insert there. So we covered all their origins on the scapula. Now we're going to talk about their insertions. So the 3 muscles of the rotator cuff that insert there are supraspinatus, infraspinatus, and teres minor. So supraspinatus, infraspinatus, and teres minor all insert there. So that's a pretty important landmark. So that's the greater tubercle. Again, most of that lateral portion of the proximal humerus, that's your greater tubercle. And then the lesser tubercle, so we'll spin it back around. So now you're looking, again, at a straight anterior view. The lesser tubercle is this little guy, but it is the more obvious projection of the two. So like on a real bone, the lesser tubercle is more prominent. It's easier to see. So the lesser tubercle is the site of insertion of the last of our rotator cuff muscles, the subscapularis. So subscapularis, last of the rotator cuff muscles, inserts there at the lesser tubercle. And I saw something in the back palpating. You can't actually feel these. Depends on how big your deltoid is. Makes it the smaller your deltoid is or the thinner your deltoid is, the easier it is to find. And they're tough to feel, but basically if you found your coracoid, so if you took your thumb and you found that obvious knob, if you slide laterally just a little bit, you poke in really hard, you're going to have to jab, it's going to be uncomfortable. If you rotate your arm in and out, you'll feel those 2 little knobs pop up underneath your finger. Feel a knob and then another knob. It's subtle, it takes practice, but you actually can palpate those. And so if you do that, there's another landmark in the middle. So you got greater tubercle, lesser tubercle, and then there's an indentation between the two. So that is the Intertubercular Groove, which is on the back of the sheet. It's also known as the Biceps Brachii. So the little indentation between the greater and lesser tubercles, so this indentation here, this little valley, is the Intertubercular Groove. So something is inter, it's between. So intertubercular means between the tubercles. And a groove, obviously, is some sort of an indentation. So the intertubercular groove between the greater and lesser tubercles. Again, also known as the bicipital groove because the long head of biceps, that tendon sits in there. So biceps, your big elbow flexor. Again, two heads. Short head originates with the coracoid process. Long head actually originates at the top of the glenoid. Those two run together, and then you have one common belly here in the middle of your arm. All right. And then, I missed the surgical neck. I didn't talk about that. The surgical neck is right here. So that is the area where it narrows just inferior, or actually we should be using proximal distal. So just distal to the tubercles. So this area where the bone narrows, just distal, so farther from the body to the tubercles, that's the surgical neck. So the anatomical neck is more proximal. Again, right here where the cartilage ends is the anatomical neck, and the surgical neck's down here. All right, and then the last landmark is actually about halfway down, so I have to zoom out some. So the last landmark is the deltoid tuberosity. So I should have probably talked about tubercle and tuberosity. Tubercles are projections, so are tuberosities. In general, a tuberosity is a larger projection or rough area on the bone than what we see with a tubercle. So typically tubercles are smaller projections, tuberosities are larger projections. It's not always that way. So for example, the deltoid tuberosity, so what I'm going to do is spin the bone around a little bit. There we go. Okay. I'm going to zoom in some. And so you'll see this kind of flat area here. It's about halfway down the shaft on the lateral aspect of the bone. It's sort of like a sort of flat area. That's the insertion of the deltoid muscle. So deltoid is your big superficial shoulder muscle that you can see in most people. It kind of caps the shoulder. So all of this is my deltoid. So deltoid inserts there at the deltoid tuberosity. So hopefully that'll be one of those softball questions I ask you on the quiz. What muscle inserts here at the deltoid tuberosity? Don't overthink it. It's deltoid. So that's the significance of that landmark. All right. So those are all of those things. So those are all landmarks. A word about lab before I forget. So after class, I have students visiting with me on WebEx, which is awesome. I'm excited about that. But that'll be done about noon. So what I'll do sometime between noon and 1 is I'll send you an email, say, okay, here are the lab section assignments. So if you're in the 8 o'clock group, half of you are going to come from 8 to 8:40. The other half are going to come from 8:50 to 9:40 or whatever that time is. So just check your email before you come tomorrow to make sure you come during the right lab slot. And if for some reason you're like, hey, I need to come during the early one, not the later one, send me an email, let me know, and I'll shuffle it around. I'm just trying to keep less than 10 in there at any one time. Okay, so those are the landmarks. So now we'll go back to the old slideshow. Okay, so we covered all the bones, and again, if you want to, rather than using the anatomy app, because the landmarks aren't in the app, so again, you can use these graphics. All right, so here's a few more things to cover, and then we'll call it good. Remember last time we talked about osteokinematics. So osteo means bone, kinematics deals with movements. So osteokinematics deal with bone movement. And so the way I used them last time, I talked about glenohumeral. Now we remember that that's the shoulder joint. So I talked about glenohumeral flexion, which is this. So from anatomical position, bringing your arm straight up, that's glenohumeral flexion. That's osteokinematic motion because all of you could see me do that. That's a really big, obvious motion where the one bone is rotating around another. So those are osteokinematics. In order for osteokinematics to occur, we have to get arthrokinematics. So what arthrokinematics are, so anything arthur, A-T-H-R, anything arthur, deals with a joint. So arthrokinematics deal with movements inside of a joint. And so these are really small movements between the two bones inside of the joint that allow for osteokinematic motion. And there are three types of arthrokinematic motions, and those are rolls, slides, and spins. So typically with joints, there are a combination of concave and convex surfaces. So a concave surface is one that curves in, right? It makes a cave. As opposed to a convex surface is one that curves out. It protrudes out. So if we're thinking about this in the context of the glenohumeral joint, let me go back to my main body. All right, so the humeral head then is our convex surface that curves out. The glenoid cavity is our concave surface. So most joints then are a combination concave, convex surfaces, and then they fit together. And that helps ensure joint stability. So by having them not be just flat planes on one another, that makes it more stable because they kind of a little bit fit into each other, sort of like a lock and key. So it improves joint stability. It also increases surface area of contact between those two, and so it helps distribute forces. So in a joint like your hip, that's going to be really important that we maximize surface area across which we distribute those forces so that not any one area gets overloaded. So it makes it less likely that's going to happen. So those are our concave, convex surfaces. And so what ends up happening then is that you get rolls, slides, or spins of one surface on another. So for example, if I'm going to abduct my arm, so if I'm going to bring my arm straight out to the side, in order for that to happen, I had to get a combination of rolling, actually all three, rolling, sliding, and spinning in the glenohumeral joint for that to occur. So effectively what ends up happening, and sorry to keep switching programs on you, but effectively what ends up happening is as he lifts his arm out to the side, so as he abducts the arm, the humerus is going to roll, so it's going to roll like this on the glenoid. But as it rolls, it's also going to slide inferior. It's going to slide down a little bit. That's really, really important, and that's one of the primary jobs of the rotator cuff. Because if the humerus just rolled, right, so if it rolls, it's going to move up a little bit. If it just rolls, it's going to close down on this space underneath the acromion. So this space here is called the subacromial space. So if the humerus rolls up, it's going to close down that space. Well, why does that matter? The reason that matters is if I add some muscles to this guy, add a few layers, there we go. There's a muscle that sits in that space. That's the supraspinatus muscle. And so if your humerus rolls up, and it does that all the time, every time you lift your arm over your head, well, you're going to end up pinching the supraspinatus muscle between the acromion and the humeral head, and so you're going to end up fraying and eventually tearing your supraspinatus muscle. So in order to prevent that from happening, the rotator cuff muscles, so this one's subscapularis, this one's supraspinatus, those two will contract, and the other two, all four of them will contract, and rather than allowing just a straight upward roll, they'll pull the humerus against the glenoid and cause it to slide back down a little bit. So you get that simultaneous roll and slide to help keep that subacromial space underneath the acromion open so we don't pinch the supraspinatus muscle. So those are your arthrokinematics, combinations of rolls, slides, and spins inside of a joint that allow for osteokinematics. So if any of those are limited, then that's going to affect joint motion. So for example, this will be my last example. If somebody, after, let's say, an ACL injury in the knee, most commonly after an ACL injury, people have what's called an extension lag. They can't fully straighten their leg. You got scar tissue on the back of the knee. And so effectively what happens there is you can't slide the tibia forward some. And so because of that, you can't fully extend the knee. So in order to get full range of motion back, we got to get that slide back. So we got to get the arthrokinematics back to get the osteokinematics. All right. Nice job today. So we'll see y'all tomorrow in the lab. So remember, look for your lab time via email this afternoon. And then we'll finish this stuff, move on to the actual joints and stuff on Friday. Friday will be more interesting. I have injuries and stuff to show you. So Friday will be a little bit more interesting than this. But you got to know the basic anatomy before you know what you heard. So we'll see y'all on Thursday and then hopefully again on Friday.